So, hello everyone. Am I audible? Is the screen clear so that we can start the session? This is the session of anatomy MCQs. So, this is the session of anatomy MCQs. Let me just check. Am I audible? Is the screen clear? Yes. So, yes, I am audible and the screen is clear. So, we can start the session now. So, we can exactly start the session now. Let me just check. Okay, so Ulsi. Okay, hello dear Ulsi. Okay, so yes, let me just check. Good evening Ulsi. So we can start the session now. This is the session of the MCQ sessions. So we have already covered nerves MCQ, but this is the session where we are going to start with the median nerve. So yes, my dear aspirants. Okay. Okay. So yes, I am audible and everything is fine. My voice is okay. Okay, so let me just give you a quick introduction about myself and about the platform of Unacademy. So myself, Dr. Monalisa, and I have done my MD Anatomy from Armed Force Medical College. Yeah. So special class features, when I am talking about special class features, it's an interactive session where the learners can interact. Polls are conducted, they can respond to the polls, raise your hands, get your doubts clear, write itself when the session is going on. Never ever miss a session. So once the session is finished, you can also download the PDF notes, which will be highly beneficial for you. Anytime, anywhere, read from the top educators of Unacademy platform. These are the benefits which can be gained if you're watching the session on the free platform of Unacademy. So use the code ANAT10 and do present for this free session. Okay. Now, my dear aspirants, let's talk about the important information which I want you to tell, that NEET PG All India mock test is going to happen on 26th Feb, and the timing of the session is 9 a.m. The timing of the session is 9 a.m. So do enroll in this test by using the code ANAT10. You can present for this test. This will be highly beneficial for you. When I am talking about the plus subscription, all 19 subjects are completed in a very systematic way. You can assess both live and recorded version, and you can study from India's top educators for the medical field. Compete in live tests and quizzes, study on the device of your choice and assess approximately, so not approximately, it is more than 25,000 MCQs which can be assessed by you. So these are all high yield MCQs, clinical MCQs from all 19 subjects, which was made by the top educators of Unacademy platform, and explanation is provided for each and every MCQ. So use this code and do get 10% discount if you are wanting to take the subscription. Now, iconic subscription, all the benefits of the Unacademy, all the recorded version, live lectures and full syllabus, QBank can be assessed. Along with it, you can also have the access to the prep ladder. That means clinical integrated essentials, dream notes of the prep ladder, QBank 3, rapid revision snapshots, and treasure dream notes 2021. All these will be assessed. You can use this code ANAT10 and get an additional discount of 10%. Now, congratulations to the toppers. Congratulations to the toppers of FMG 2021 examination, December session. Best wishes of mine is given to you so that you can crack your NEET PG exam with a very good rank. My dear aspirants, the details of educator curated test series detail is there. Do enroll in this test. These are on the free platform. Use the code ANAT10 and enroll in this test. This will be highly beneficial for you. Focus FMG session 2022 comprehensive batch is started, so you can take the subscription, be the part of this session. You can be the part of Target Next 2023 batch. You can be the part of Mission INICT batch. For any of the subscription, you can use my code ANAT10. For any of the Unacademy iconic subscription, you can use this code and get 10% discount. My dear aspirants, I would also like to start with the topic now, that is the median nerve. So we have already covered up the ulnar nerve. Now this is the topic of median nerve which I want to cover today. So we will study in detail about the median nerve, and then I will also have the MCQs at the end of the session. So let's talk about the topics. So I just want to tell you the subtopics in which we are going to complete this entire details of median nerve. So we want to study about the formation of median nerve. We want to know the details of course and relation. We want to correlate with the branches of median nerve and also the clinical anatomy related to median nerve. So basically, let's start firstly with the formation of median nerve. Okay, so first thing is to start with the carpal tunnel syndrome. It will come, yeah, sure, carpal tunnel syndrome will come. Carpal tunnel syndrome is the space which is lying below the flexor retinaculum and the median nerve is compressed. Yes, absolutely correct. I'll see at that area the median nerve is compressed by the flexor retinaculum. So let's talk firstly with the formation of median nerve. So formation of median nerve is by two roots. One is the medial root and the other is lateral root. So see here. So when we are talking about medial root, it is derived from the medial cord and it is having the root value. It is derived from the ventral rami of C8 and T1. When I am talking about lateral root, it is formed from the lateral cord of brachial plexus and it is from the ventral rami of C5, C6 and C7. So together it will lead to the formation of median nerve, and why median nerve is called as labral nerves. Okay. So now, yes, I'll see all, let me complete the gross anatomy, then the clinical anatomy and then the MCQ. So that carpal tunnel compression of median nerve has been included today. Don't worry about that. Okay. So it is the thickest nerve. So these are all important points. For MCQs, labral nerve, why? Because labor nerve, why? Because it is giving innervation to large muscles of the forearm. So it is also called as labor nerve. It is the thickest nerve of the brachial plexus. Which is the largest nerve of brachial plexus? Any idea? Which is the largest nerve of brachial plexus? Largest nerve. Which is the largest nerve, dear? Largest nerve is the radial nerve. Thickest nerve is the median nerve. Now let's see the formation. So let me highlight this diagram. Okay, once again brachial plexus. So see here, as I told you, it is the thickest nerve. Okay, it is the thickest nerve of brachial plexus. My topic is brachial plexus, so I am talking about brachial plexus. Okay, so yes, now see here. Yes, you are correct that trigeminal, but I am talking here about the brachial plexus. So, abhi brachial plexus ka thickest nerve kaun sa hoga? Median nerve. So, see here, this is the median nerve. Let me explain you its formation. So, what I have told you that it is having two parts. So, it is having two components. So, it is formed, its lateral root is formed from the lateral cord of brachial plexus. So, here you can see, okay, its lateral root is formed from the lateral cord of brachial plexus. Can you appreciate here? This is the lateral cord of brachial plexus. So, from the lateral cord of brachial plexus, its lateral root is formed. Okay? Yes. And its medial root. When I am talking about its medial root is formed from the medial cord of brachial plexus. So, see here, this is how the brachial plexus is formed. Medial root from the medial cord and lateral root from the lateral cord. Lateral root from the lateral cord and median nerve from the medial cord. So, this together leads to the formation of this thickest nerve of the brachial plexus, which is called as the median nerve. Is it okay? So, I have outlined the median nerve. This is the median nerve which we are going to study today. Median nerve is formed by taking contribution not only from the medial cord but also from the lateral cord, and then leads to the formation of the medial nerve. So, it is having two roots. Now, let's talk about the course. So, firstly, I would like to talk about the course in the axilla. So, what is the formation? We know that cords of brachial plexus, is located in the axilla. That means formation of median nerve is also in the axilla. So, it is formed in the axilla, and the location is, the crux point is that its location is lateral to third part of axillary artery. It is lying lateral to third part of axillary artery. Median nerve. So, see here, if I enlarge this diagram, so can you see one of the nerve is joined? Can you see one of the nerve is, so let me use another color. See here, this nerve, when you will see, it is joined by forming the medial and lateral cord, and it is running lateral. So, this nerve is what? This nerve is median nerve, and you can basically see its location is lateral to, its location is lateral to axillary artery. To be more specific, third part, but you can say lateral to axillary artery. It is formed by taking two roots. One is the lateral one and the other one is the medial one. Got it, everyone? Okay. Now, course and relation. So, let's talk about course and relation. So, it descends lateral to brachial artery. If I talk about its further course in the arm, it is descending lateral to brachial artery. Its course is lateral to brachial artery. It is descending lateral to brachial artery, and in the middle of the arm, it is crossing in front of the brachial artery. It is crossing in front of the brachial artery. So, if I talk, firstly we have done with the course in the axilla. Subsequently, it is crossing in front of the brachial artery. See here, I am enlarging this diagram. So, here you can see the median nerve. As you can see in this diagram, so when it is coming towards the arm, when it is going towards the arm, you can see the median nerve. This is the brachial artery. Median nerve is crossing anterior to it. So, you can see median nerve is crossing anterior to brachial artery, and again it will reach. After crossing anterior to brachial artery, so firstly have the relation. सबसे पहले मैंने क्या बताया, the most initial part what I have told you, that the most initial part I have told you that median nerve was lateral to axillary artery. Now axillary artery becomes brachial artery at the lower border of teres major. After that, median nerve is crossing anterior to brachial artery, and at the level of cubital fossa it will come to medial aspect. So see here, at the level of cubital fossa, as you can appreciate, it is lying on the medial side of brachial artery. So please by heart this course. What is the course? The course of median nerve, when it is formed at the lower part in the axillary region, firstly it is lying lateral to axillary artery. In the middle of the arm, it crosses anterior to brachial artery, and when it reaches the level of cubital region, it is lying medial to brachial artery. See here, this is the diagram which I want to enlarge. So yes, everyone, can you see this? Yeah. Can you appreciate this? Yeah. So here when you will see, this is the reason exactly So in this diagram you can see here exactly the median nerve is lying medial to brachial artery. So two important structures relation you can appreciate here. If I am talking about median nerve and brachial artery, so median nerve is lying medial to brachial artery at this level. Okay, pronator teres muscle is lying medially, as we know it is lying medially, and brachioradialis muscle is lying laterally at the region of cubital fossa. Now further down, when it is lying in the elbow, it is also lying behind the bicipital aponeurosis. So what is bicipital aponeurosis? Before crossing it is lateral, after crossing it lies medially. Absolutely right, Ulsi. Absolutely perfect, Ulsi. You are perfect. Okay, great. Yeah, that only what I want to explain. So Ulsi is absolutely right. So thereafter it lies behind bicipital aponeurosis. So what is bicipital aponeurosis? My dear aspirants, biceps brachii muscle. When I am talking about biceps brachii muscle. Okay, when I am talking about biceps brachii muscle, this biceps brachii muscle inserts in the form of tendon at the radial tuberosity, at the level of radial tuberosity. But when it comes medially, it will form aponeurosis. So it will form aponeurosis in the medial aspect. So see here this diagram. Now, can everyone appreciate this diagram? So, my dear aspirants, two structures are there. One is the brachial artery and the other is median nerve. So, if you will see, these two structures are lying in the cubital region, and you can here appreciate that these two structures are covered by one of the aponeurosis which is arising from biceps tendon going medially. So, which structure is covering these two structures? Median nerve and bicipital aponeurosis is covered by median nerve, and that of brachial artery is covered by bicipital aponeurosis. So it is covered by which structure? Bicipital aponeurosis. Is it clear? Is it clear to everyone? Now further down. Now I would like to show you a diagram which is cadaveric image. So I would like to show you this cadaveric image where you can appreciate the relations more nicely. Okay, so see here. Let me enlarge this diagram. So I am enlarging this diagram, all of you. This is the diagram which is the cadaveric image of showing the cubital region and the median nerve. So here, let me firstly outline the muscles. Okay. So this is the muscle which I am outlining. This is the PT, means pronator teres muscle, and this muscle which you are seeing here is BR, brachioradialis muscle. Okay. So, and there will be an imaginary line at here, that will be the imaginary line will be the base. So this will be the base of cubital region, and this joining point is called as the apex of the cubital fossa. Now here, if I talk about the structures, relations and all, so we know that pronator teres structure is lying medially. It is lying medially. Okay, and we know that brachioradialis is L for lateral. Okay, now the two structures which can be clearly seen here. So you can see here, this is the median nerve. This is the median nerve. So very nicely you can appreciate the median nerve. Okay, you can appreciate the median nerve very nicely, and you can see lateral to, if I talk about, so here brachial artery has been removed, but you can see here lateral to brachial, lateral to median nerve, you can see the relation of another tendon. Which tendon is this? This is the biceps tendon. This is biceps tendon. So this is the biceps tendon. So biceps tendon is lateral to median nerve, and this structure which you are seeing is the median nerve. Okay, so median nerve is medial, biceps tendon is lateral. Biceps tendon is lateral. So is it okay? Now moving to further relation. So when it enters into the forearm, it will pass between the two heads of pronator teres. Thereafter, if I talk about its further course, it is passing between the two heads of that. Thank you, Alsi. Okay, great. So when it is traversing into the forearm, it passes between two heads of pronator teres. What is the clinical importance? That means it can get compressed in between the two heads of pronator teres. It can get compressed in between the two heads of pronator teres. Thereafter, it passes deep to the tendinous bridge which is formed by the two heads of flexor digitorum superficialis. So please note down, it passes between the two heads of pronator teres. Thereafter, it passes deep to the flexor digitorum profundus. Flexor digitorum profundus. Now, so see this diagram. So what I have told you, I want to appreciate this in this diagram. I want to appreciate that relation. So see here, the median nerve. What I told you, it will pass between the two heads of pronator teres. So can you appreciate, this is PT, this is pronator teres muscle, and here you can appreciate it is passing between the two heads of pronator teres muscle, and at times it is compressed between two heads of pronator teres muscle called as pronator syndrome. Okay, same way you can see here, after that median nerve is traversing deep to flexor digitorum superficialis. After that it is traversing deep to flexor digitorum superficialis muscle. Forearm. Thereafter it will descend between flexor digitorum profundus and flexor digitorum superficialis. Got it? 5 cm above the flexor retinaculum, approximately 5 cm above the flexor retinaculum, it emerges behind. 5 cm above the flexor retinaculum, it emerges behind the lateral edge of flexor digitorum superficialis. It will emerge behind lateral edge of flexor digitorum superficialis. Got it? Now, forearm. See here. So what I told you, this is flexor digitorum superficialis, and here you can see median nerve is traversing just deep to flexor digitorum superficialis. Okay. After that, what you can see in this diagram, flexor digitorum superficialis has been removed, dissected out. So what I have told you, thereafter it is traversing. So here you can appreciate the median nerve. This is the median nerve. This is the median nerve. Here you can appreciate the median nerve is resting over flexor digitorum profundus. So what you can see, flexor digitorum profundus. So thereafter it is traversing between flexor digitorum profundus. This is the median nerve. It will traverse. After that, it will traverse between flexor digitorum superficialis and flexor digitorum profundus. Thereafter. Now, my dear aspirants, if I talk about median nerve, as one of the student has also told about the carpal tunnel. So yes, when I am talking about that, it will enter into the palm in the carpal tunnel. What is carpal tunnel? The space below the flexor retinaculum or transverse carpal ligament is called as carpal tunnel. So median nerve passes below the transverse carpal ligament. It passes deep to flexor retinaculum when it has to enter into the palm. So see here. Can you appreciate here? So yes, you can clearly appreciate here that this is the median nerve. See here, this is the median nerve, and in here you can see this is traversing. So here I want you to show this flexor retinaculum. This is the flexor retinaculum. Okay, this is the flexor retinaculum. So you can clearly see actually the median nerve. If I talk about median nerve, it is traversing behind or below the flexor retinaculum, but ulnar nerve. If you will see, this is the ulnar nerve. Ulnar nerve is traversing superficial to flexor retinaculum. So this is the difference. So ulnar nerve, palmar cutaneous branch of ulnar nerve, palmar cutaneous branch of median nerve. So palmar cutaneous branch are traversing above, but the thick median nerve main trunk is passing below flexor retinaculum, Now, in short, I would like to no, Alsi, it is not waiter tip deformity. Carpal tunnel syndrome is not waiter tip deformity. Carpal tunnel syndrome में हमारा median nerve compress होता है and thereafter waiter tip deformity is in upper trunk palsy. Okay, waiter tip deformity is seen in case of upper trunk palsy where C5 and C6 nerves roots are involved. Okay, I will come to clinical aspect, don't worry. Now see here, branches of median nerve. So median nerve is giving innervation to basically all the muscles of forearm, all flexors muscles of the forearm. Okay, so it is giving basically muscles of the forearm, that all flexor muscles, and it is giving innervation to few hand muscles. So I will write that name, motor supply, don't worry, please write down. Branches of median nerve. So branches of median nerve, that is motor branches, that is muscular branches. So it supplies all muscles, that means flexor muscles of forearm. It supplies flexor muscles of all flexor muscles of forearm except the one which is supplied by ulnar nerve, Which muscle is supplied by ulnar nerve? Flexor carpi ulnaris and medial half of flexor digitorum profundus. So we have already finished the ulnar nerve. In that we have seen two muscles are getting innervation from ulnar nerve. One is flexor carpi ulnaris and the other is medial half of flexor digitorum profundus. Now next, in hand it supplies following muscle. It is giving innervation to thenar muscles. Okay, it is giving innervation to thenar muscle. So we have got three thenar muscle: abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and also it give innervation to first and second lumbrical muscles in the hand, first and second lumbrical. So these are motor innervations. Okay, so it is giving innervation to basically all the muscles, flexor muscles of forearm, that is pronator teres, flexor digitorum superficialis, flexor pollicis longus. Actually, okay, and in the hand it is giving innervation to thenar muscles. actually deep muscles of forearm. So we have not done with the muscles. So don't worry, I will have the muscle classes of the forearm. Then you will understand we have got 3 deep muscles of forearm. One is flexor pollicis longus, other is flexor pronator quadratus, and we have got flexor digitorum profundus, lateral part. So flexor digitorum profundus, lateral part, flexor pollicis longus or pronator quadratus is getting innervation from deep branch of median nerve. The deep branch of median nerve is called as anterior interosseous nerve. All other muscles are supplied by the median nerve itself. So in the hand, it is giving innervation to first 2 lumbricals and the 3 thenar muscle, abductor pollicis brevis, flexor pollicis brevis and opponens pollicis. So yes, Narayan Jat, welcome to the session. Now, I would like to share this image where you can appreciate cutaneous branch of median nerve, Okay. So this is the diagram where you can appreciate cutaneous branches of median nerve. Okay. So see here, when we are talking about cutaneous, we have got palmar cutaneous branch and palmar digital branch. So on the dorsum of the hand, it is giving innervation to nail beds. Which nail beds? Lateral 3.5. Lateral 3.5. Actually, this part will also get lateral 3.5. And if I talk about the palmar cutaneous branch, okay, it is giving innervation to the lateral 3.5 of the fingers of the palm, as you can see in the diagram. Okay. Now let's talk about the lesions of median nerve. So let's talk firstly the lesions at the level of elbow. Lesions at the level of elbow. Okay. So my dear aspirants, all muscles, so see here, all muscles paralyzed except flexor carpi unlaris and flexor digitorum profundus. All muscles like flexor carpi unlaris and flexor digitorum profundus. When we are talking about Oshner clasping test, the case will be of pointing index finger. Okay. So actually what happens, generally we know that if we are talking about the flexor group of muscle, it is basically getting innervation from median nerve. So the flexion action is gone. Flexor digitorum superficialis and also the lateral fingers are getting innervation from the median nerve, that is flexor digitorum superficialis and the lateral half of the flexor digitorum profundus. So the fingers are not able to bend or flex, and this condition is called as Oshner's clasping test, which is positive in median nerve injury. Ulnar deviation will be seen in attempted cases of flexion of the wrist, and inability will be there to flex the terminal phalanx of the thumb. Why? Because flexor pollicis longus muscle. The reason is that flexor pollicis longus muscle is also getting innervation from the median nerve. So inability to flex the terminal phalanx of thumb because flexor pollicis longus is also getting innervation from median nerve. Clinical testing. So which are the clinical testings which can be done to see the median nerve integrity? Now, as I have told you, which thenar muscle is getting innervation from? All the thenar muscle is getting innervation from median nerve. So of that group, one is abductor pollicis brevis. So abductor pollicis brevis is getting innervation from median nerve. So if you tell the patient or the person who you are examining to keep their palm onto the table and with the palm facing upwards, okay, and you keep a pen, the examiner will keep a pen above it and they will want to touch the patient have to touch it. So for touching the tip of pain, the action which has to be done is abduction. The action which has to be performed is abduction of thumb. So my dear aspirants, the abduction of thumb is done by abductor pollicis brevis. Now abductor pollicis brevis is paralyzed. Why it was paralyzed? Okay, Yes, Alsi. So, abductor pollicis brevis is paralyzed because median nerve is injured. Median nerve is injured. Abductor pollicis is paralyzed because median nerve is injured. So, abduction of finger is not possible and the patient is not able to touch the pen of examiner, and this is called as the abductor pollicis test, which is also called as pen test. So, this is the pen test. So, pen test is positive in case of median nerve injury. Now, yes, Osner clasping test, pointing index finger. So, when you want to clasp and when you want to clasp your fingers and you want to flex, the fingers has to be flexed, okay. But here the index finger flexion is not possible. Why? Because we know that flexor digitorum superficialis and also the lateral fingers, and the flexion is not possible because there is paralysis of lateral aspect of the flexor digitorum profundus, and also the flexor digitorum superficialis is gone. So, there will be pointing index finger. So, index finger is not able to be flexed, it will be straight. So, that is called as pointing index finger. Alsi, is it okay? Now, median nerve injury at the level of elbow. When median nerve injury is occurring at the level of elbow, now my dear aspirants, in our hand, here is the thenar muscle. Below the thumb, यहाँ पे क्या है? Thenar muscle है. Below little finger, this is hypothenar. Hypothenar muscles are getting innervation from ulnar nerve, but these muscles are getting innervation from median nerve. Thenar muscles are getting innervation from median nerve. Thenar muscle is involved and paralysis occurs, so there will be flattening of this thenar eminences. So, this is slightly elevated. If you will see in your hand, Narayan Jet and Alsi, if you will see in your hand, your own hand, you will see there is slight elevation of this thenar eminences. So, this is due to thenar muscle. If this thenar muscle are paralyzed, there will be flattening. And also adductor pollicis muscles. So, adduction and opposition. So, when you touch, the thumb touches the other finger, this is called as opposition. So, abduction is not possible in the thumb, also opposition is not possible because both these muscle, abductor pollicis brevis and opponens pollicis is paralyzed. So, our hand will be like ape thumb deformity. This will be ape thumb deformity. So, in case of median nerve injury, there will be ape thumb deformity, there will be pen test positive because thenar muscles are paralyzed, and adductor pollicis is working, but adduction of thumb is possible. So, it is medial, no adduction. Adduction is possible. Why adduction is possible? Because adductor pollicis muscle is not paralyzed, it is getting innervation from which nerve? Ulnar nerve. So, adductor pollicis or adduction of thumb is possible. Is it okay? Okay? Yes. Carpal tunnel syndrome. So, one of the students from the very beginning is telling about carpal tunnel. So, carpal tunnel syndrome is entrapment syndrome, means medial nerve is compressed. Okay. Carpal tunnel syndrome का मतलब होता है, it is the median nerve compression. The other word, it is a case of median nerve compression. Carpal tunnel syndrome means median nerve compression. It is causing median nerve compression. Got it? It's a case of median nerve compression. ठीक है? Now, the incidence is more common in case of females 50 and above years. 50% cases are bilateral and most commonly it is seen in dominant hand. Dominant hand means most of us are dominant hand कौन सा होता है? Right hand होता है. Some cases में left hand भी होता है. So, cause of median nerve is, so we know that median nerve is traversing below flexor retinaculum, it is traversing in osteofibrous tunnel, that is called as carpal tunnel. So, median nerve can be compressed below the flexor retinaculum in this fibrous tunnel, in this fibro-osseous tunnel, that is called as carpal tunnel. So, see this case, see here. In this diagram, I can appreciate here that this is transverse carpal ligament. What is the other name of transverse carpal ligament? It is also called as, transverse carpal ligament is also called as flexor retinaculum. It is also called as flexor retinaculum. So it is also called as flexor retiniculum. So below this flexor retiniculum FR, the median nerve can be compressed. Why? Because it is passing deep to it. Here also you can see this is, if this is the transverse carpal tunnel, transverse carpal ligament, median nerve can be compressed below this. You can clearly see this is median nerve, it can be compressed below it, and then it is compressed, then the case is called as carpal tunnel syndrome. Now, what are the clinical reasons? What are the clinical reasons where carpal tunnel space can be narrowed? Okay, what are the clinical reasons जब हमारे पास वो carpal tunnel space is lessened? The tunnel can be narrowed. The tunnel can be narrowed when there is arthritic changes in the wrist joint. It is a case of rheumatoid arthritic or arthritic case. There is fracture, anterior dislocation of lunate है या complication of Colles fracture है. Soft tissue thickening in case of myxedema or acromegaly, edema, obesity and pregnancy. So these are the causes or reasons of carpal tunnel syndrome. These are the causes and reasons of carpal tunnel syndrome. The reasons are arthritic changes, the reasons are edema, pregnancy, obesity, anterior dislocation of the carpal bone, lunate, complication of fracture, Colles fracture, soft tissue thickening in case of myxedema and acromegaly. Now, I would like to show you this image once again, how the median nerve is compressed below flexor retiniculum and why ulnar nerve is not compressed. So, let me enlarge this diagram. All of you, can you appreciate this? Now, see here, I am highlighting flexor retiniculum with green color. So, this is flexor retiniculum. This is flexor retiniculum, no doubt. Now, the structure which will pass superior to flexor retiniculum, the structure which is passing superficial to flexor retiniculum is not compressed. That means ulnar artery and ulnar nerve are not compressed. They will be not compressed. Palmaris longus tendon is also passing superficial to it. So that means ulnar nerve, ulnar artery, palmaris longus muscle, these are not compressed. The structure which will be compressed will lie below flexor retiniculum. So कौन से structure compressed हो जाएंगे? Median nerve definitely compressed होगा. The structures are flexor digitorum superficialis, flexor digitorum profundus tendon and flexor pollicis longus. Okay, so see here, other structures being compressed. The structures which can get compressed are median nerve, flexor digitorum superficialis tendon can get compressed. Flexor digitorum profundus tendon can be compressed because passing deep to it, and flexor pollicis longus tendon can be compressed. Okay. Other important thing which can be appreciated here, one of the tendon, as you can see here, this tendon, this is flexor carpi radialis tendon. Okay, so this flexor carpi radialis tendon is not compressed. Why? Because it is passing between, if you will see this diagram, it is passing between the two slips of flexor retiniculum. The structures which can be compressed is shown in pink color highlighted. Okay. No, swan neck deformity and all, these are, okay, that is, so that is the fractures and all, okay. So now let me tell you about, so all of you please see the highlighted structures which can be get compressed, the structures. So pink colored structures are you seeing? Pink color structures. So pink color structures are the highlighted structure which is passing below flexor retiniculum and that can be compressed. Okay. 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 So yes. Swan neck deformity is the digit, phalanx and the digit abnormality. Okay, buttonhole, swan neck, these are the digital involvement. Okay, phalanx are involved in that case. So let's see the carpal tunnel syndrome reasons we have done. We have done with the, now my dear aspirants, okay, my dear aspirants, just see the carpal tunnel syndrome symptoms. So my dear aspirants, when you will see the patient, when you will see the patient of carpal tunnel, they will have impairment of the finer movements. Okay, they will have the impairment of the finer movements. Okay, so yes, so what happened? I'll see swan neck deformity. Actually, swan neck deformity is involvement of distal and that of proximal interphalangeal joint. Okay, so that is like a flexion of the distal interphalangeal joint and extension of proximal interphalangeal joint. That is consist with the phalanx being involved. We know that flexor, it is not directly related with medial nerve. It's an injury of the fingers. Okay, move ahead. See here. So impairment, my dear aspirants, symptoms: impairment of finger movements, swing action, knitting and the pricking, paresthesia in numbness in the lateral 3.5 of the digit and the palm. Lateral 3.5 of the digit and the palms will be seen. Now actually sometimes what happens, the symptoms are so grave and so severe that at times the person wakes in the night to without of this, because of the pain, paresthesia and picking sensation, numbness, the person has to wake up in the middle of the night. In such cases, there can be operation done and the release of flexor retinaculum can be done. Okay. There can be release, there can be cutting and release of flexor retinaculum which can be done. Okay. See here, paresthesia. So most commonly earlier syndrome, I'll say paresthesia. Now let's see the carpal tunnel syndrome on examination, which are the features which is seen. So see here, on examination, when the examination is done, there will be wasting of thenar eminences. The person will give the complaint of wasting of thenar eminences. Can you see in this image? Thenar muscles. So thenar muscles is wasted, muscular atrophy हो गया, thenar muscles का atrophy हुआ, thenar muscles atrophy, wasting हो गया. Okay. Now hyposthesia on the palmar aspect or radial 3.5 of the digit. Also skin over the thenar eminences is not affected because palmar cutaneous branches are passing superficial. Now my dear aspirants, tenal signs. Now, tenal signs is positive. What happens? We know that at the level of when it is passing from the wrist and coming to the palm, it is passing deep to flexor retinaculum. So, by a finger tapping or by a you tap it by any instrument or by fingers, you tap it here. So, what will happen? We are increasing pressure over flexor retinaculum. That means we are increasing pressure in the carpal tunnel. So, the sign and symptoms of the patient will become more pronounced. So, that means this is a case of tenal sign positive. So which test is done for median nerve injury? अगर median nerve injury हमारे patient में suspect होता है, if we are suspecting that this is the case of median nerve injury, we will perform tenal signs and tenal signs are positive. Why? Because increase of pressure on flexor retinaculum will give the sign and symptoms become more pronounced. Okay, so tenal test is positive. Now Fallon test. Now I will explain. Now we know that at the level of the wrist, the carpal tunnel space is reduced. Now if we will do our fingers like this, okay, this is the position. So if the wrist is wrist flexion test is done, so the pressure over median nerve is, this is Fallon test, pressure over median nerve is again increased and there will be Fallon test positive. In case of carpal tunnel syndrome, Fallon test is positive, Tillon's test is positive. Now, if you want, there will be no sensory impairment on the palm because palmar cutaneous branch is passing superficial to flexor retinaculum. Cutaneous sensation much nahi hota hai because palmar cutaneous nerves is passing superficial. What is the treatment? Sometimes we will treat the condition. For example, अगर reason है myxedema, रीजन है आपको ओबेसिटी, रीजन है आपका इंक्रीज इन फ्लूइड और मिक्सिडिग्मा, एक्रोमेगाली, रीजन है आर्थराइटिस, रीजन है फ्रैक्चर ऑफ ल्यूनेट बोन. सो वी विल ट्रीट द कंडीशन. At times the case is very severe, the sign and symptoms of the patient is very severe, so we will go with the treatment, and the operation which is performed is carpal tunnel release, okay, partial or complete division of flexor retaniculum. So the condition will be partial or complete release of flexor retaniculum and carpal tunnel release. See here, can you see here, exactly endoscopic carpal tunnel release is done, and we will go with the division of flexor retaniculum. So flexor retaniculum or the transverse carpal ligament is cutted out, so that pressure is released over median nerve. Okay, cutting of the flexor retaniculum. Got it everyone? Okay. Now Pronator syndrome. Now let's go with the Pronator syndrome. Pronator syndrome. Now other reason of Pronator syndrome, median nerve can be compressed. As if you remember the case, I told you median nerve is passing between two heads of pronator teres muscle. It is passing between two heads of pronator teres muscle. So in between two heads of pronator teres muscle, it can be compressed. Okay. So deep to biceps aponeurosis, the reason where it is also important for MCQ, the places where the median nerve can be compressed. Deep to biceps aponeurosis between two heads of pronator teres or below the fibrous arc of flexor digitorum superficialis. So please note down the reasons where median nerve will be compressed. It can be compressed below biceps aponeurosis, it can be compressed between two heads of pronator teres, it can be compressed below flexor digitorum superficialis fibrous arc. So this is the three reasons. Deep to bicipital aponeurosis between two heads of pronator teres, Pronator syndrome, through the fibrous arch of flexor digitorum superficialis, the reason of pronator teres syndrome or compression of median nerve. Clinical features. The clinical features will be pain and tenderness in the proximal part of anterior forearm, weakness of all the muscles supplied by median nerve, and sensory impairment on the palm of the hand. Why यहाँ पे sensory impairment क्यों हो रहा है? Now, my dear Alsi and Alsi and that of Narayan, so यहाँ पे palmar cutaneous sensation भी lost है. Pronator teres के syndrome में cutaneous sensation भी lost है, because the compression is high above. Because the compression is not at the level of the wrist, it is high above. So it is high above, that means the involvement is also of palmar cutaneous branch. The involvement is also of palmar cutaneous branch of median nerve. यानी यहाँ पे palmar cutaneous branch of median nerve भी compress होगा, because before the origin of palmar cutaneous branch of median nerve, the compression occurs, like compression at pronator teres syndrome, compression below flexor digitorum superficialis, or deep to bicipital aponeurosis. Okay. Now we have done with the median nerve, and before ending the session, quickly we will solve few MCQs. I will show you how the MCQs come from this topic. Yes, Alsi, cutaneous nerves are intact in case of carpal tunnel syndrome, but it is compressed if the injury is at a higher level. Because before giving palmar cutaneous nerve only, it was compressed. Okay. And at the level of wrist में क्या होगा? Palmar cutaneous nerve is passing superficial to flexor retaniculum. Okay. Now question number 1. So few MCQs अभी हम discuss करते हैं कैसे MCQs आते हैं इस topic से. A 45-year-old Caucasian female presents to your office with numbness of right palm. After taking a detailed history and doing a physical examination, what is suspected? Median nerve injury is suspected at the level of wrist. Before reaching to the wrist, the median nerve courses between. So this is about the course. So what is the right answer? Okay, before reaching the level of the wrist, median nerve is coursing between which two structure? Biceps coracobrachialis, flexor carpi ulnaris, flexor digitorum profundus, flexor digitorum superficialis and flexor digitorum profundus, olecranon and medial epicondyle, supinator and head of the radius. So yes, I got an answer. Yes, Alsi, you are absolutely right. Just now I have taught. Okay, so Narayan, you joined late. Maybe that may be the reason. I have just taken the session and I have told that flexor digitorum superficialis and flexor digitorum profundus. Okay, yeah, so C is the correct answer, that it passes between flexor digitorum superficialis and flexor digitorum profundus. Okay, that is the correct answer. That is the course of median nerve. Biceps and coracobrachialis is not the right answer. It is high up. Flexor carpi ulnaris से relation जब होगा तो that is with the ulnar nerve. Olecranon and medial epicondyle भी ulnar nerve से related है. Supinator muscle and head of radius is related to radial nerve. Radial nerve. So the correct answer is C. Absolutely correct. Now, see here, median nerve enters the flexor retiniculum, enter the flexor compartment of forearm under the cover of tendinous ring. So when it is entering into the forearm, as I have already told, it is passing between humero-ulnar and radial head of FDS. Firstly, it will pass between the two heads of FDS muscle. Thereafter, it will pass between FDS and FDP. Thereafter, it traverses between FDS and FDP before entering into the wrist. So that is the correct answer. So we will go with C as the correct answer. Okay. Now, biceps and coracobrachialis is the wrong one. Why it is wrong? Why it is wrong? The reason it is wrong is musculocutaneous nerve is the terminal branch. Musculocutaneous nerve is the terminal branch of lateral cord, and we know that both biceps and coracobrachialis is getting innervation from musculocutaneous nerve. It's a branch of lateral cord of brachial plexus. It pierces the coracobrachialis muscle. It pierces the coracobrachialis muscle and passes below actually the anterior muscles of arm. Arm is getting innervation from biceps brachii and brachialis muscle. So musculocutaneous nerve is also giving innervation as lateral cutaneous nerve of forearm. It also gives innervation as lateral cutaneous nerve of forearm. Okay, so biceps and coracobrachialis is not the right answer because it is related with musculocutaneous nerve. It is not related with median nerve. Now, so that means it is the wrong option because it is related with musculocutaneous nerve. Why? It is related with musculocutaneous nerve and it will cause weakness in the arm flexion and loss of cutaneous sensation in the lateral aspect of the form. So, agar musculocutaneous nerve, if musculocutaneous nerve is compressed, the sign and symptoms will be weakness in the arm flexion and sensory loss of the lateral forearm. Flexor carpi ulnaris and flexor digitorum profundus is also the wrong answer. Why it is wrong? In the lower part of forearm, we know that flexor ulnar nerve, what I have told you also, that ulnar nerve is related at this level. Ulnar nerve is related on flexor digitorum profundus and overlapped by flexor carpi ulnaris. So if ulnar nerve is involved, Kiran Bhardwaj, ma'am, when you will teach radial nerve? Okay, I will teach it on 28th. 28th Feb. Is it okay? 28th Feb. I will teach it on 20th Feb. Yes, LC. So it is not the right answer because it will lead to medial claw hand, paralysis of intrinsic muscles of the hand. Yes, so it is also wrong. Absolutely correct. Radial nerve, all of you will present live. I will teach on the 20th Feb. Now, the other option, that is the olecranon and medial epicondyle of humerus. So, olecranon and medial epicondyle of humerus is also the wrong answer, and the reason it is wrong, why? Because this is again related by ulnar nerve. This is again the course of ulnar nerve. Ulnar nerve is coursing posterior aspect of arm and is related to dorsal aspect of medial epicondyle between medial epicondyle and olecranon process. Actually, ulnar nerve I have completed, and if you will see the course, this is the course for ulnar nerve, not the median nerve. So, it is not the right answer. Thank you. Most welcome, Kiran. Now, Option E, that is supinator muscle and the head of radius. So supinator muscle and head of radius is again the wrong one. Why it is wrong? Because this is the relation for radial nerve. Radial nerve is passing through supinator muscle. I have not taught you the radial nerve, but when I will take the class of radial nerve, you can see supinator muscle is related with radial nerve and it will lead to the condition. If radial nerve is involved, the clinical symptoms will be of wrist drop, not carpal tunnel syndrome. Not carpal tunnel syndrome. Okay. Now, so question number 2. Recurrent branch of medial nerve does not innervate which of the following muscle? Question number 2. Apply your common sense and give me the answer. Apply your common sense. Question number 2. Recurrent branch of medial nerve does not innervate which of the following muscle? Okay. So, recurrent branch of medial nerve does not innervate which muscle? So, medial nerve is not getting innervation to which muscle? Anyone wants to give the answer, or I will come up with the answer? So, my dear, the correct answer is adductor pollicis. No, adductor pollicis. If you remember adductor pollicis, I have told you, ulnar nerve में मैंने बताया था, adductor pollicis is getting innervation from ulnar nerve. Adductor pollicis is getting innervation from ulnar nerve, not from medial nerve. Rest all muscle, it is a muscle of thenar eminences. It is the muscle of thenar. These are all the muscles of thenar eminences. Yes, Narayan, you are absolutely right. These all are the muscles of thenar eminences. So this will get innervation from the medial nerve. Recurrent branch of Yes, actually yes, E is confusing. Recurrent branch gives innervation. So E should not be there. So you are also correct, Elsie. Yes, E should not be. Recurrent branch innervate all above is also wrong. So both E is wrong and both B is wrong. So here B and E both are wrong. So both Elsie and Narayan is correct. Both Elsie and Narayan is correct. Yes, all of the above भी नहीं होगा, because we can say that recurrent branch of medial nerve is innervating. All the above is not right, because adductor pollicis is getting innervation from ulnar nerve. Yes, dear. Yes, Narayan Jet. Yes. So we have got the correct answer both E. We have got the correct answer both E and B. Great Elsie and great Narayan Jet. So ठीक है, it's nice. We will have all the sessions with you. You just be present live so that it will become more interesting for me also. So recurrent branch of ulnar nerve innervates abductor pollicis brevis, flexor pollicis brevis, opponens. But the deep branch of ulnar nerve innervates adductor pollicis. I have given the explanation. Ulnar nerve innervates adductor pollicis, rest all muscle, flexor pollicis brevis, opponens pollicis, and abductor pollicis brevis are getting innervation from median nerve. Done. So one more. Patient tries to make a fist. Patient is trying to make a fist. Okay, fist का मतलब क्या होता है? Flex करना. But second and third fingers are partially extended. वो flex नहीं हो रहा है. What is the injury? Very easy. Patient is trying to flex, okay, but the flexion is not possible. Second and third fingers are not able to be flexed. What is the reason? Which nerve is involved? Which nerve is involved? Narayan Jet, all of you should come for my sessions on the special class. Narayan Jet, whenever I take a session on special class, you will be provided with the PDF notes also. You have to come for my special free sessions on the Unacademy. I will inform you. Don't worry. Shruti Gupta, hi, hello, Elsie, Narayan. I will tell you when I will take a session on the special free platform of Unacademy. So I will tell you and inform you in the group. You come there, you will get the PDF notes. Okay. So which is the answer? Median nerve, absolutely correct. Yes, the correct answer is median nerve. So this is causing the compression of median nerve, absolutely correct. So see here, this is Benedict signs. Actually, this is the Benedict sign which result from peripheral neuropathy, and it is affecting the muscles of the hand. So when there is median nerve injury, you try to make a fist. The two fingers, that lateral two fingers are basically middle and index fingers. It is not able to flex because lateral part of FDP and all the FDS are paralyzed, but lateral part of FDP on the lateral part is paralyzed. So lateral two fingers are not able to be flexed, and this is called as benediction hand. This is condition of benediction hand. This is positive in case of median nerve injury. This is positive in case of median nerve injury. Don't worry, YouTube पे भी sessions है, तो you can always, if you feel anything to be revised, you can see the sessions of mine. Now, when median nerve is injured, patient often exhibit the sign of hands, that is benediction attitude, when the person tries to make a fist. When the person tries to make a fist, second and third digit are partially only flexed, not fully flexed, because lateral part of flexor digitorum profundus is also paralyzed. We know all the tendons for the flexor digitorum superficialis is paralyzed, but lateral part of flexor digitorum profundus is also paralyzed. So flexion of distal phalanx is not possible in the lateral fingers, but it is possible in medial fingers, that is fourth and fifth, because ulnar nerve is not paralyzed. Medial finger में benediction attitude is not seen because ulnar nerve is not paralyzed, but median nerve is paralyzed, so it will be seen in the lateral fingers. Flexion of metacarpophalangeal joint of digits second and third is also affected due to loss of lumbrical muscle. So we know that first and second lumbrical muscles. We also know that first and second lumbrical muscles is also getting innervation from median nerve. So flexion of metacarpophalangeal joint on lateral side will be also affected. Okay, done with this? Done, my dear aspirants. So before ending, few important points. All India mock test is going to happen. All India mock test, those who want to have the real feeling of examination, they should enroll in this test by using my code ANAD10. The test is going to happen on 26th of Feb. 9 AM is the timing. So get enrolled for this All India mock test. Use my code ANAD10 to be present for the All India mock test. And we know that now Unacademy is also providing printed notes made by the top educators of Unacademy platform. So when those who are interested for taking the plus subscription, they will be provided with all the subject notes of the Unacademy, all the doctors and the educators who are highly experienced. So those who are interested can take the subscription. They can use my code and get 10% discount. They can get 10% discount. My dear aspirants, before ending, I would like to tell that on 28th of Feb, I will take radial nerve. Also do present for the live session of mine on the Unacademy app by using the code ANAD10. So this is the unlock code which can be used by you. My code is ANAD10. This is an unlock code. Also for taking the subscription, 10% discount will be provided to you. So all of you do like, subscribe the channel of Future Doctors, that is Unacademy Future Doctor. It will be highly beneficial for you. So yes, my dear aspirants, I'll see. Okay. What metacarpophalangeal? Okay, I got a question. I'll see metacarpophalangeal joint is ellipsoid joint. Yes, I'll see. You are perfectly right. It is metacarpophalangeal joint. Okay, yes, you are absolutely right. I will write here. Yes, metacarpophalangeal joint is ellipsoid joint functionally. It is ellipsoid joint functionally, and it is condyloid joint. It is condyloid joint structurally. It is condyloid joint structurally, but functionally it is ellipsoid joint. Correct? Correct, I'll see. क्या टॉपिक होगा 28th Feb को? टॉपिक होगा रेडियल नर्व. टॉपिक will be radial nerve. All the best. Keep studying. Thank you so much. All the best. Thank you. Thank you, aspirants. I am ending the session. Thank you. Thank you, everyone. So, yes, we will meet on 28th Feb. When joints class has been taken on the Future Doctor Unacademy. Go and see, check my all lectures and sessions. I'll see, you can check my all previous session. Joint means general anatomy joints I have taken. So upper limb ke joints in detail I haven't taken. I will take in the coming, but general joint I have taken. So general anatomy joint I have taken. You can just see my previous session. I'll see previous session, the YouTube link will be there. So you search for joint class by Dr. Monalisa on Unacademy Future Doctors. Is it okay? Taken. It is taken. Taken. It is taken, dear. Thank you. All the best. Keep studying. Thank you so much. Thanks, dear. Okay, great. Great. So yes, you have to just check for it and it will be available. So you can just check.